Hello everyone, my name is Joseph Cavatayo and I'll be presenting a case on reconstruction of an unstable Cavovarus foot performed at Henry Ford Hospital. Our patient was a 60-year-old female presenting with chronic left lateral ankle pain for roughly 1 year, where she had been diagnosed and treated for peroneal tendinitis, conservatively treated with NSAIDs, physical therapy, and intermittent peroneal tendon steroid sheath injections. She presented in a wheelchair and noted that she can no longer work as a cleaner, no longer go upstairs, and despite this conservative treatment, she's had persistent pain. She has a long-term history of uncontrolled diabetes mellitus with the most recent A1C of 7.8%. Her physical exam showed a positive anterior drawer sign and subtalar tilt test. She had tenderness over her peroneal tendons, and finally, her Cavovarus foot did correct on single hindfoot rise. X-rays of the patient's ankle were taken at the visit. The lateral X-ray demonstrated a normal calcaneal pitch and normal Meares angle. The mortise or oblique view demonstrated a varus alignment of her forefoot and hindfoot. On the right shows an MRI taken a few months prior to her preoperative visit. It demonstrated a rupture of her CFL, or calcaneal fibular ligament, and ATFL, or anterior talofibular ligament. The peroneal longus tendon also showed rupture and edema on the axial view. Final assessment of this patient in clinic concluded that the patient has an acquired unstable Cavovarus foot deformity with rupture of her CFL, ATFL, and potentially peroneus longus tendon. The plan was to perform a modified rostrum with augmentation to restore lateral ankle stability, a lateralizing calcaneal osteotomy in order to decrease hindfoot-driven disease, and a left peroneus longus to brevis transfer in order to reduce plantar flexion of the first ray and decrease stress placed on the lateral ankle. To begin, I'd like to describe the Cavovarus foot disease. It is characterized primarily by high longitudinal plantar arch, shown in black, a varus position of the heel in red, forefoot equinus in green, and pronation or plantar flexion of the first ray, shown in orange. Finally, I found that understanding the previously mentioned steps of reconstruction of the Cavovarus foot is easiest when considering how each restores the tripod of the foot. The bottom picture on the right shows a normal foot where, looking directly anterior to posterior, there is relatively neutral formation and shows a balanced tripod, where in the picture on the right above shows a Cavovarus foot that has a tripod that is obliquely oriented, placing increased stress on the lateral ligaments as the tripod is falling to the right or lateral rather than being balanced. First was the lateralizing calcaneal osteotomy. The osteotomy created a cross-section in quadrants through the calcaneus to create a free posterior piece, as shown quadrant by quadrant in the left pictures. That piece was then lateralized to bring the hindfoot back into a neutral position and alleviate any hindfoot-driven etiology. It was then fixed with cannulated 5/0 compression screws. Next is the peroneus longus to brevis transfer. We took an anterolateral approach to the ankle, which allowed us to identify her large and severely thickened peroneus longus tendon. This was released distally and tacked to the peroneus brevis in a side-to-side transfer. As a result, the peroneus longus can no longer plantar flex the first ray, which alleviates forefoot stress, and now everts the foot with the peroneus brevis to decrease lateral stress on the foot. Finally, the modified rostrum with augmentation used the same anterior lateral incision of the foot, where we identified a severely thinned ATFL and incompetent CFL. The CFL was anchored to its attachment on the distal fibula. The ATFL was also anchored to the distal fibula from its attachment site on the talar neck. Both were done with the foot in dorsiflexion and along with a Gould modification, which is reinforcement of the inferior retinaculum of the foot. This helped to restore lateral ankle stability. These three interventions helped to correct her Cavovarus deformity and helped hopefully reduce her pain in the lateral foot by offloading the force and reinforcing stability of her lateral ankle. Thank you for listening.